Recording in progress.
Bienvenidos todos a una nueva sesión del Webinario Internacional de Educación Continua en Vía Aérea, organizado por el Programa de Anestesiología y Reanimación de la Universidad Diego Portales de Chile. El programa de Anestesiología y Reanimación de la Universidad Diego Portales es dirigido por el doctor Ricardo Latrop Allende y tiene como objeto lograr formar un especialista capaz de ejercer la anestesiología en forma integral, entregando al paciente una atención acorde con la evolución de la especialidad, adaptándose a los cambios epidemiológicos y al desarrollo de la tecnología. Las autoridades de nuestra Facultad de Medicina, encabezadas por la doctora Patricia Muñoz Casas del Valle, decano de la Facultad de Medicina, y el doctor Antonio Eblenza, de la Escuela de Posgrado de nuestra facultad. Ellos son los quienes avalan esta actividad académica en la facultad. Esta actividad académica también es apoyada por la Sociedad Europea de Vía Aérea, EAMS, y también por la Sociedad Española de Anestesiología y Reanimación y Terapéutica del Dolor. Este año tenemos muchos invitados internacionales de primer nivel, y algunos de ustedes ya los han conocido, otros vendrán en los próximos meses. Recuerden que tenemos una reunión mensual y en esta oportunidad tenemos el grato honor de contar con el doctor Paul Baker de Nueva Zelanda. Recuerden que con su inscripción y asistencia, nosotros seremos capaces de certificar vuestra participación en este webinario. Contamos también con traducciones simultáneas a 3 idiomas, portugués, inglés y español, dado por la empresa Traducciones Remotas, a quienes agradecemos su invaluable ayuda. Así que los invitamos a participar. Ustedes pueden levantar la mano haciendo el gesto del botón de reacciones que tiene en la parte baja de su pantalla. También pueden hacer comentarios, saludos. Nos encanta dónde nos están viendo, en el chat que está también a vuestra disposición, o también pidiendo la palabra de manera oral, haciendo algún comentario. Perdón. En esta oportunidad tenemos al doctor Paul Baker, quien es anestesiólogo neozelandés, nativo de Auckland. Completó su residencia en 1986 y es anestesiólogo del Hospital de Auckland y del Hospital de Niños Starship desde 1986. Su principal área de interés es la enseñanza y la investigación en el manejo de la vía aérea. En 2014 recibió un doctorado de la Universidad de Auckland, cuya tesis se tituló Mejorando la calidad y seguridad en el manejo de la vía aérea. En 1996 fundó el curso Airway Skills, al que asisten más de 200 anestesiólogos, intensivistas y urgenciólogos al año, tanto en Auckland como en Sydney, Australia. Es el inventor del simulador ORSIM para la fibroscopía flexible, que está diseñado para mejorar y evaluar las habilidades de manejo de la vía aérea superior e inferior. Es el único también simulador de alta fidelidad que usa realidad virtual. Es profesor asociado del Departamento de Anestesiología de la Facultad de Medicina de la Universidad de Auckland. Es miembro de múltiples sociedades internacionales de vía aérea, tales como la SAM, EAMS y DAS. Es miembro del directorio y es el actual presidente electo de la SAM, Society for Airway Management, de Estados Unidos. Es además el fundador y director de la Red de Vía Aérea de Nueva Zelanda. Ha recibido numerosos premios de diversas entidades internacionales. Es revisor de varias revistas de anestesiología, examinador de maestrías y doctorados de la Universidad de Auckland e invitado a paneles de expertos para la confección de guías clínicas. Es también invitado permanente a cursos y congresos internacionales como conferencista experto. Tiene más de 90 publicaciones en revistas científicas y un extenso currículum que avala el gran aporte que el Dr. Baker ha hecho y sigue haciendo al manejo seguro de la vía aérea. Por estas sobradas razones, nos honra con su presencia en este webinario de la Universidad Diego Portales y me complace presentarles a continuación al Dr. Paul Baker, quien nos iluminará en este tan importante tema del manejo de la vía aérea difícil pediátrica. Perfectamente. Antes de ofrecerle la palabra al doctor Baker, quisiera que por favor respondieran un par de preguntas que el mismo doctor Baker ha enviado para esta ocasión. La primera pregunta es: ¿cuál cree usted que es el mejor dispositivo para intubar a un bebé con vía aérea difícil? Tenemos 4 alternativas: laringoscopía directa, hoja Macintosh, laringoscopía directa, hoja Miller, videolaringoscopía y broncoscopio flexible. También están disponibles en inglés. Se está produciendo la participación de la votación de los participantes. Esperamos que todos puedan dar su opinión. Yo no sé si es igual arriba o abajo. No, en inglés puede que tengamos algunos participantes de habla inglesa, no lo sé. ¿Estaremos listos, parece?
Y está compartiendo resultados.
Perfecto. Entonces, de las respuestas a la pregunta, hay una votación compartida entre la videolaringoscopía y la broncoscopía flexible. También hay un buen porcentaje de personas que han optado por la laringoscopía directa en la hoja Miller. Aquí está en inglés, es lo mismo. Laringoscopía, videolaringoscopía y broncoscopía flexible.
That's very interesting.
¿Quieres hacer algún comentario, Paul, sobre esta votación?
Well, I think we can just maybe discuss that at the end of my presentation because it's very relevant to what I'm going to say.
Muy bien. Muy bien. Detenemos el uso compartido. Vamos a la segunda. Hay pregunta. Esperamos la segunda pregunta. Segunda pregunta es: ¿cuál es la concentración máxima de óxido?
Eu gravei o primeiro. Eu já entrei no palco fazendo peça pro pessoal, né, mãe?
Una inducción de anestesia por inhalación para un niño? La voy a repetir. ¿Cuál es la concentración máxima de óxido nitroso
Eu nem queria saber se era gravado ao vivo, dane-se.
para usar en la inducción de anestesia por inhalación para un niño? Ahí se está produciendo la votación. Muchos están prefiriendo, diciendo 40 o 50%. Eso. Muy bien. Finalizamos la votación. Compartimos. Paul, hay casi un empate entre 50% y 40%. Yo sé que tú te vas a referir a esto.
I have results for this. It's very good.
Muy bien. Muy bien. Vamos entonces, dejo con ustedes al doctor Paul Baker. Yeah, okay. Please, Paul.
Hello, everybody. Can you hear me? It's
Yes.
Paul Baker here. Are we ready to go?
Sí,
Excellent. I'm sorry about that false start. My talk seems to have been hacked. But anyway, we're going to start again. So Thank you for joining this webinar. I want to talk to you today with an update in pediatric airway management. And I've already had an introduction, so I'll just get going. Thank you very much. Next slide. So here I am in New Zealand, and I'm 9,000 kilometers from Chile and a 16-hour difference. So it's actually 8:20 on Sunday morning in Auckland on a nice day. Next slide, please. And I did have quite a lot of time and not much to say, but now some of my time's gone because my talk was hacked, but never mind, we'll keep going. Next slide, please. So just in case some of you have to leave or fall asleep or don't concentrate, I thought I'd get my most important message over to you now, and that is to maintain oxygenation and avoid trauma whenever you're managing an airway, particularly a child's airway. So these are basic principles which I was taught by John Henderson, who you can see a picture of, and he was the lead author of the first Difficult Airway Society guideline. He's retired, but he's a great man. And please follow those basic rules and you'll have fewer problems. Next slide. So today I want to talk about these 7 subjects, and I'll break my talk up into little segments so that you can maybe get up and shake off and we'll move on. But first of all, I want to talk about planning the difficult airway in a child. Next slide, please. And I just want to point out that 25% of the world's population are under the age of 15. That is related to socioeconomic circumstances. And you can see in Africa, 40% of children are under the age of 14. And in more affluent countries, that percentage has dropped. But throughout the world, about a quarter of all of the population are children. And yet you would expect that would be reflected in our literature and in our teaching and everything we talk about in airway management. But it doesn't quite seem to be the case. Next slide. These are some current practice guidelines, and I'm sure you're familiar with them. There's the American Society, there's the Difficult Airway Society, Canadian Airway Focus Group, and there is an international group working on a universal project to manage the difficult airway. And a lot of these current guidelines have authors who are pediatric anaesthetists. I'm involved in a couple of those, but I think that's a good move that we are considering children when we write these guidelines. Next slide, please. And of course, there are some specific pediatric guidelines for managing difficult airways in children. Unfortunately, I looked at these and a lot of them are out of date. And I'll just give you an example of what I'm talking about. But you can see there are guidelines from Italy, India, Germany, UK, and France. But most of them are over 5 years old. So they're getting a little bit out of date with the literature and they're due for updates. Next slide, please. So this is an example from the Difficult Airway Society about bag mask ventilation. And the first thing you'll notice on the top there is it talks about children aged 1 to 8. Well, of course, children are children from the day they're born. And in fact, infants and neonates are the group that are the most problematic in terms of airway management. So we really need to include those children. And also, you don't really become an adult until you're more than 8 years old. So I'm not sure why we're sticking with 1 to 8. But that's a very sensible approach in that algorithm of managing a difficult mask ventilation in a child, and I have no objection with that. Next slide. Next slide, please. This is talking about intubation in children. And there are a few little issues here. You can see on the top left, I had an arrow, and they talk about no more than 4 attempts at direct laryngoscopy. So first, from recent research that I'm going to show you in a minute, if you fail with direct laryngoscopy, it's suggested you move direct to video laryngoscopy or flexible immediately. I'm sorry, somebody's fiddling with this. And you certainly shouldn't have 4 attempts. It's probably more like 2 attempts. It's good that they're continuing oxygenation. That's vitally important, and I've already mentioned that. Then they come down into the middle of the slide, and you can see, consider 1 attempt with flexible. Well, I would think maybe that should be increased. And at the bottom, they talk about consider indirect laryngoscope if experienced in their use. And I think we're all gaining experience with video laryngoscopy. So I think that needs to be updated. Can we move on to the next slide? So this is the emergency pathway for cannot intubate and cannot ventilate. And it makes a lot of sense, calling for help. The problem here is there's a big emphasis on cannula cricothyrotomy leading into jet ventilation. And I'll have a lot to say about that later in my talk. But the current thinking is that we move more to a tracheotomy and place a tube and give bag ventilation. Can we just move on to the next slide, please? Now, I just want to briefly talk about the management of airway obstruction in children. And I think this is quite a nice way of looking at it. You can divide airway obstruction into 2 broad groups. First, anatomical or mechanical airway obstruction, and secondly, functional airway obstruction. Just move to the next slide. So this is anatomical or mechanical airway obstruction. And these conditions basically can be treated by using our hands. So for example, if there's inadequate head positioning, you reposition in the head. That's obvious. If the child has large obstructing lesions in the airway, such as tonsils and adenoids, or they're obese, or it's a pharyngeal problem, you can place airways to overcome that. But again, it's a manual solution. Difficult face mask, you can optimize that with 2 hands on the mask with another person ventilating. And if there's secretions, well, you suction the airway. If there's collapse of the airway, atelectasis, you can use recruitment maneuvers. And gastric distension, you can place an oropharyngeal airway. So they're all very simple maneuvers that I'm sure you're familiar with, and you use your hands to do that. So that's anatomical. Next slide, please. Functional airway obstruction, this is more reliant on medication or drugs. So inadequate depth of anesthesia, obviously we deepen the anesthetic or use a muscle relaxant. Laryngospasm, again, a muscle relaxant or a drug like propofol. Opioid-induced rigidity, muscle relaxant again. Bronchospasm, we use bronchodilators, maybe adrenaline. So they're very distinct, different ways of dealing with airway obstruction, depending on its anatomical or functional airway obstruction. Can we move on to the next slide? Right, now I want to talk about induction of anesthesia, and I have a study that we recently published that I'd like to share with you. So can we move to the next slide? So I was interested in children. Often we can't formally do 3 minutes of pre-oxygenation because the child just won't tolerate it. And they may be a bit uncooperative, they could be crying. And so we place a face mask often and do an inhalation induction. And by the way, internationally, over 60% of all inductions in children are inhalation. So you place a face mask and you would include a volatile agent and the child goes to sleep. And I was wondering whether that induction of the anesthetic with oxygen mixed with other gases was also working as pre-oxygenation. And if so, how much oxygen do you need to adequately pre-oxygenate? So the first question is, how much oxygen do you need and what is the consequence of subsequent hypoxemia? And we found that the background hypoxia rate following an inhalation induction was 5%. Can you move to the next slide? So we did this by looking at anesthetic records in our hospital, and now look back several years and analyzed electronic records, and we looked at 27,000 of them. And we found that the overall incidence of hypoxemia following an inhalation induction was 5%. And then when we looked at changing the concentration of oxygen to less than 60%, the incidence of hypoxemia started to increase. So we saw more hypoxemia if we used less than 60% oxygen. We didn't actually see any change whether we used nitrogen, that's air, or nitrous oxide in the 40%. What was important was we had to give a minimum of 60% oxygen. Can we go to the next slide? So here's a pictorial account of my analysis, and you can see so long as you're giving 60% oxygen or more, the incidence post-inhalation induction stayed at about 5%. But when you start decreasing below 60% oxygen, the incidence of hypoxia, if it was between 60 and 40%, went up 1.2 times, and below 40%, 2.3 times. Next slide, please. Next slide. So we've been using nitrous oxide since the 1800s. And when they started using it, they didn't even have oxygen. So they gave 100% nitrous oxide. They had no way of measuring hypoxia, so I'm sure the patients became hypoxic. Then when oxygen came along, they reduced the nitrous oxide down to 86%. And then at some point in history, it was decided to use a 2-to-1 ratio. So 2 was the nitrous oxide, 1 was oxygen, 66% nitrous oxide, 33% oxygen. And you can see from our study that would have led to more hypoxia. Now we're advocating a minimum of 40% nitrous, 60% oxygen. That way we keep our hypoxia rate to a minimum. Next slide. Okay, now the next thing I want to discuss with you is oxygen treatment. Next slide, please. So this is a well-known study by Jonathan Hardman. It was a computer-based, we just go back a slide, a computer-based study. Previous slide. Yeah, so you can see in this graph, they did pre-oxygenation in a virtual way for 3 minutes. And then there's a dotted line, and that's where there's an onset of airway obstruction. And then we look at different age groups, a 1-month-old, a 1-year-old, an 8-year-old, and then an 18-year-old. And you can see the onset of hypoxia starts depending on the child's age. And the earliest child to start desaturating is a 1-monther. You only get about 2 minutes of oxygen saturation, and then you start to desaturate. And the longest is an 18-year-old. They can last about 7 minutes with an obstructed airway before they start to desaturate. Now, this is assuming all of these virtual patients had normal lungs. So pre-oxygenation does work, but it is far less effective in young children because they have less reserve, their functional residual capacity is decreased, and their closing volumes overlap the FRC. Next slide, please.
Paul, voy a dejar de compartir un momento. Puedes continuar,
Thank you.
Paul.
Can you go to the next slide? We're still having trouble with being hacked, I think. So we know that prolonged periods of hypoxia is very bad for us. And in fact, in cardiac cases, less than 60% oxygen has a very poor clinical outcome. And infants account for 55% of anesthesia-related cardiac events. So this is very bad if the saturations drop down to very low levels. But what we don't know is what do little periods of hypoxia do in terms of morbidity. Next slide. So I'm sure I'm not the only anaesthetist in the world that's seen saturations down to that sort of number. It's very worrying, and you struggle to bring it back up again, and it may only be very brief. And in fact, little brief periods of hypoxia like that don't tend to cause problems, but the trend, if you can't reverse it quickly, can be very serious. It leads to bradycardia and ultimately cardiac arrest. Next slide. So this is a study of over 1,000 children in the United States. It was a multi-center study published in The Lancet in 2016. And they found that temporary hypoxemia was the most frequent non-severe complication in these children, 9%. And the most common severe complication was cardiac arrest. And all of the cardiac arrests were preceded by hypoxia. So the most common cause of cardiac arrest in children with difficult intubations are airway complications. Next slide. Now, I found this rather shocking, that in this study of 1,000 children across the United States, oxygen is really being used during difficult intubations. Now, I know this was 2016, and there's been a lot of discussion in literature and a lot of advice offered. And I think, and I would hope, that the world has changed and that we're using apneic oxygenation techniques. But even in this study, there were some people using nasal cannulas or modifying nasopharyngeal airways or using endoscopy masks. So there are ways to deliver oxygen and maintain oxygenation, but that's a critical step. Next step. Next slide, please. So this is an editorial by John Fiaggio, who was the lead author of that study I've just shown you. And really, it's very simple. We must be thinking more about oxygen and using it as a supplement to prolonged intubation attempts. Next slide. So the recommendation is to think about using oxygen, and it can be low flow, high flow, through a conduit, but we have to be careful with oxygen because it can cause problems, particularly barotrauma, and I want to talk about that now. Next slide. Here's a study. It was a randomized clinical trial of 457 children, and they had 3 groups. One was direct laryngoscopy without oxygen. The other group was direct laryngoscopy, but they used oxygen by taping on a catheter onto the laryngoscope. And the third group was a video laryngoscope with oxygen. And you can see the onset time to a 1% drop in oxygen saturation. And the direct laryngoscopy group only had 30 seconds before the onset of hypoxia. The other 2 groups had much longer periods where they had, before hypoxia started, 67 seconds or 75 seconds. So it's pretty obvious adding oxygen during your intubation attempt is very effective at prolonging your safe period before the onset of hypoxia. Next slide, please. And we can deliver oxygen in many ways. You can, in some laryngoscopes, you can actually apply it to the laryngoscope blade. This is a TrueView Trufotec blade. Next slide. These are all just examples. We can move through these quickly. You can give oxygen through a nasal tube as you're intubating, and you have the advantage of monitoring your progress with capnography as well. So I use this routinely in my nasal intubations. Next slide. Or you can use buccal oxygen by cutting down a ray tube and putting it in the side of the tongue. Next slide. Nasal prongs are very commonly used. I'm sure you use them wherever you are. And that's low flow oxygen, 4 liters a minute. Next slide. And this is an older child having a rigid bronchoscopy done. There's oxygen attached to that bronchoscope and it's open to atmosphere at the top end, but also we're supplementing that with nasal high flow. Next slide. This is a case report of a patient we had in our hospital that had aspirated peanuts. And the surgeon put in a bronchoscope to try to remove the peanuts, and this child desaturated. They were receiving oxygen on the side port of the rigid bronchoscope, which you can see in the picture. So the bronchoscope was removed and the anaesthetist ventilated the patient, and then they had another go. So the bronchoscope was put in, but this time the saturations dropped earlier and they went down lower. So they came out a second time, reoxygenated and put it in a third time. This time the child had a brief respiratory arrest and had to be resuscitated. So they pulled out and did mass ventilation, and they were about to give up because it was too dangerous. But then the anaesthetist put on nasal high flow, and that supplemented oxygen delivery around the side of the bronchoscope. And there was only a 1 millimeter gap between the bronchoscope and this child's trachea, but that was enough to increase the oxygen delivery by 50%. The oxygen saturation stayed above 90%, and they were able to remove all the peanuts. That's fine so long as you have adequate outlet for all that oxygen. If you have an obstruction around the bronchoscope and you don't have the bronchoscope open to atmosphere, there is a risk of barotrauma. So you have to be careful, but it is an effective way of ventilating during some of these difficult cases. Next slide, please. These are the flow rates we use for our high flow nasal oxygen, and I'm sure you're using this technique. It's very useful and has improved airway management significantly, I think. Next slide, please. Another thing that's often forgotten is awareness. So if you're dealing with a difficult intubation, it often takes longer than normal. And you have to be mindful that you have to continue the anesthetic while you're trying to instrument the airway. And that's very easy to do with intravenous anesthesia. Next slide, please. So here's a child being intubated with a video laryngoscope. They're receiving nasal oxygen. It's hard to see under the anaesthetist's hands there, but there are nasal prongs on. But also we're giving intermittent boluses of propofol. So we are mindful of awareness that can take a bit longer. And with this technique, you have plenty of time. You don't have to rush, and the child's asleep, and there's no risk of awareness. Next slide, please. Here's a study where they used an air track, and they connected the tracheal tube, which is in the side port, to an oxygen supply. And they connected the oxygen to the tracheal tube using a little connection off the bottom of a Hudson mask. And you can see that little connection actually has a hole. in the side. You can see the top right, there's a little wee hole. Anyway, that was published, and the whole idea of this publication was to show the benefit of giving oxygen during a difficult intubation. But we actually noticed how they connected the oxygen to that tracheal tube, because when the tube was passed through the cords, they inflated the cuff. And in fact, at that point, there was no exit for the oxygen being supplied down the tracheal tube. It was directly connected to oxygen and to a flow meter. So I wrote a letter to the journal, and they published that because that was a recipe for barotrauma. So when you deliver oxygen below the vocal cords, you have to make sure that oxygen can get out again. And luckily, and they didn't mention it in the paper, but luckily that little connection had that tiny little hole, and that was enough to equalize the pressure to atmosphere. Next slide, please. This was a neonate that had a flexible bronchoscopy done. They put the bronchoscope down into the lung, and the child rapidly desaturated. They came out and they realized there was a pneumothorax, so they placed a chest drain. Then they were worried about the other lung, so they went down into the other side, and the same thing happened. The child desaturated, they came out and they found a pneumothorax on that side. So they put in bilateral chest drains. Then they realized that they were delivering oxygen through the bronchoscope. And when it went down, it wedged and then caused barotrauma. And they published their results, which, I mean, that may be considered a reckless thing to do, but it's good that they published this because it's a warning to everybody to be careful if you're giving oxygen through a bronchoscope. Next slide, please. Now I want to talk about tracheal intubation. Next slide, please. And I want to point out that intubation in children overall, in all children, that's all age groups, is actually easier than in adults. And you can see the figures there, 1.37% versus 9% in adults. So difficult laryngoscopy can be easier and difficult intubation can be easier. But when you're looking at infants versus older children, it's quite a different picture. So infants, difficult laryngoscopy is 4.7% compared to 0.7% in older children. So the children that tend to cause most problems are the little ones, infants and neonates. Also, difficult laryngoscopy is a lot more difficult in children having cardiac surgery because of the high incidence of syndromal children. And also difficult intubation changes with age. So some syndromes, it becomes more difficult, like Treacher-Collins, whereas others become easier, like Pierre-Robin. So it's a rather complex picture. But the big message here is look out for the little ones. They're the troublemakers, infants and neonates. Next slide, please. Now, are all video laryngoscopes superior for all children? And there is some evidence actually in normal airways, direct laryngoscopy is just as good. So there's no superiority using a video laryngoscope. Also, there's insufficient evidence in this Cochrane review to recommend or refute video laryngoscopes in neonates. But this was a rather old study, and I'll show you some more evidence. Next slide, please. Here's a more up-to-date study published in 2020, and they found that among anaesthetized infants, so that's 1-year-olds, video laryngoscope with a standard blade improves first attempt success rate and reduces complications. So I think that's more what we're seeing. There is definitely benefit being found using video laryngoscopy. And also, if you want to know which blade to use, it tends to just be a Macintosh style blade rather than a hyperangulated. Next slide, please. So getting back to that PD registry, looking at the choice of laryngoscope used on first intubation attempt. And this is consistent with the results that you showed me in the questions that you asked before we started. So a lot of people would use direct laryngoscopy. And of course, if you think it's an easy intubation, it's quite justifiable. It could be a perfectly reasonable choice of blade at the direct laryngoscopy. And less people chose flexible bronchoscopy or video laryngoscopy. But I think the next slide is more interesting. Next slide, please. So remember, these are children with difficult tracheal intubations. The first attempt success with direct laryngoscopy was only 3%. Even though 46% chose that, only 3% was successful. Flexible bronchoscopy, and by the way, that's through a conduit, and video laryngoscopy are far more likely to be successful on first attempt. So if you know this child has a difficult airway and difficult potential intubation, I don't see a lot of sense in going straight to a direct laryngoscope. I think I would choose a flexible bronchoscope or video laryngoscope based on this evidence. Next slide, please. What about video laryngoscope versus flexible bronchoscope? Which is the better of those two? Well, in fact, similar success rates in older children, but in infants, in the little ones, flexible bronchoscope tended to be more successful than video laryngoscopy. And another advantage of the flexible is you can intubate nasally, and you can also intubate through conduits, which you can't do with a video laryngoscope. So I'm a big fan of the flexible bronchoscope. Next slide, please. Does the blade shape matter? Well, we've already alluded to this, and that Lancet paper showed us this, but for children under 5 kilos, and that's really infants, it's probably more beneficial to use what they call a standard blade, but that's a Macintosh style rather than a hyperangulated blade. Next slide. What about using muscle relaxants? Well, there's evidence here that you're better off to have your patient paralyzed. So there's more non-severe complications. That's things like hypoxia and laryngospasm if you haven't used a muscle relaxant. So you're better off to have the child paralyzed. You get fewer non-severe complications. Also, it's important to have your patient adequately anesthetized in a decent depth of anesthesia. So inadequate depth can lead to problems. Now, of course, there are exceptions, and these are rare, to using muscle relaxant. So when your child's asleep, you would not use a muscle relaxant if the child had a history of distal airway collapse, and that includes mediastinal masses and tracheomalacia, because those children, once they're paralyzed, you can get very difficult distal airway collapse that could lead to serious problems. But they're unusual, and you have to be careful with them. Next slide, please. Now, this is a little video, and I'm not sure whether we're going to be able to see it, but could the person operating my slide see if they can activate the video? This is a slide that was given to me by Sim Jagannathan, but it may not be working today. All right, so the child is actually awake, but they've had their airway topicalized, and there are various ways of using sprays. You can use a pacifier, a dummy, and inject local anesthetic gel into that, and they suck it, and the oropharynx goes numb. But once you've suitably anesthetized the mouth and the pharynx and the upper airway, You can then insert a supraglottic airway, and they've got an air cue. You can see the anaesthetist is about to put an air cue into the child's mouth. It's a pity we can't see this video, but the children accept that, and it's not too stressful for them. Once you've got that in place, we can go to the next slide and I can show you another example. Now, this child I was looking after, it had a very large cystic hygroma and they needed a tracheostomy. So I've placed a classic laryngeal mask in with the child awake using local anesthetic sprays and gel. And once the airway was topicalized, I placed the laryngeal mask. Then I did an inhalation induction through the supraglottic airway, the laryngeal mask. I applied that three-way connector, and through there I could place a flexible bronchoscope and intubate. There you are, there's a little arrow showing you. There's a three-way connector, and all the time I'm giving oxygen through the side port to maintain oxygenation, and I can give an inhalation agent to keep the child asleep, and then do the intubation that way. Next slide, please. Now, this is the most difficult intubation of my entire career. This child was diagnosed with polyhydramnios at 19 weeks gestation, and it had severe micronathia. It had fused temporomandibular joints. It had virtually no tongue, and what tongue there was all bunched up at the back. There was a cleft palate. So we delivered the child by an exit procedure. That's where you do a cesarean with the mother asleep, and you do a lower segment incision and you pull the head and shoulders of the baby out, but you keep the baby connected to the placenta. So the baby is maintained on the placenta support, getting oxygen through the mother's blood supply. You then have up to an hour to instrument the airway. It took us 22 minutes. The first of all, the surgeons had to go with a rigid bronchoscope. They tried direct laryngoscopy. And in the end, I placed a laryngeal mask and went through with a flexible bronchoscope and intubated the baby. But that has to be planned well in advance. And the key points are maintaining oxygenation and avoiding trauma. Thank you. Next slide. Now, I want to just touch on monitoring. Next slide. So, do children need oxygen when they're being transferred from the operating room to the recovery room? If the child is still unconscious, then yes, they definitely do. And the answer to that question was made back in 1987. Where a study showed that children were arriving in the recovery room with low oxygen saturations, and 28% of them were desaturated. And only half of them, or 45% of them, were actually recognized clinically. So at that point, a recommendation was made to give oxygen back in 1987. Next slide, we go ahead 30 years, 2017, this study showed actually by monitoring the child, so as well as giving oxygen, we put on a pulse oximeter to transfer the child from the operating room to the recovery room. We totally eliminated hypoxia on arrival in the recovery room. Whereas there were 6 children arriving in the recovery room, even though they were receiving oxygen. I can only think that they were not being adequately supervised during the trip from the operating room. Maybe their airway obstructed on the way, or maybe they just weren't being watched carefully. I don't know. But anyway, you can still get hypoxia even with oxygen on a face mask if you're not watching them carefully. And that's why I think it's a good idea to have a little portable pulse oximeter on. Next slide, please. And this is showing the benefit of capnography in the recovery room. And capnography picks up a lot of hyperventilation and apneas. And so that's another thing to consider to improve the standard of care in unconscious children in the recovery room. Introduce capnography. Next slide. And this is from the latest guideline from the College of Anaesthetists in the United Kingdom, published in 2021, where they say it's essential at all times in patients with tracheal tubes, supraglottic airways, or sedated to have monitoring. During transfer, or sedated patients should be monitored for all patients of all ages in all locations. If they're unconscious being transferred, you treat them much the same as you do inside the operating room. Next slide, please. So there we are. That's a patient I was wheeling from along a corridor, having had an off-the-floor procedure to the recovery room. And we have quite nice portable monitors now that we could get capnography on, an ECG, and a pulse oximeter. Thank you. Next slide. So let's talk about emergency front of neck airway. Next slide. Our hospital, by international standards, is not a very big paediatric hospital, but it is the main referral centre in New Zealand. New Zealand only has 5 million people, but all of our difficult cases for children end up at this hospital. And this hospital was built 32 years ago, and in that time we've had 5 front of neck access procedures. One was saved by a paediatrician who placed a needle and did a needle tracheotomy. The remaining 4 were all saved by surgeons doing a tracheotomy. All were successful. All those children survived. Now, I have heard some recent discussion, which I found alarming. People saying, well, if it gets to this stage, there's not much point doing anything because the outcomes are so poor. Well, I think our results would contradict that. It's definitely worth trying to do something. Next slide, please. And then the question and the big debate is, should you place a needle or a scalpel? Next slide. And we saw from the earlier guideline from the Difficult Airway Society, when I started, I showed you a guideline and they were advocating cannulas. Well, these are pediatric results, children, and this is the Airway app, which is an app you can have on your phone. It's an international source of information. It's overseen in Canada, and there were 82 cases in children. And you can see that the, sorry, these are adult cases, I beg your pardon, adult, but scalpel bougie is definitely leading the way. So for older children, that's the technique of choice, scalpel bougie from about 8 years up. Can we go to the next slide? Now, there are problems when you get down to younger children, below the age of 5, and certainly infants, 1-year-olds, and neonates. Accessing the cricothyroid membrane is very difficult. It can be very traumatic, and it's very hard to even get a needle through there because of the overlap of the thyroid and cricoid cartilage. It's a very narrow gap that you're dealing with, and also your axis of entry is at a very odd angle. You can see the pictures on the right there. So for a child, you're almost directing your needle in a cephalad direction, whereas in an adult, it's more quarterly because you have more space to put the needle through. But anyway, it's very traumatic doing that. And the current recommendation is to do a tracheotomy below the larynx. Next slide, please. This is another video. Yeah, okay. This was an elective tracheostomy being done on a baby. And before they started, they put a camera through the vocal cords, and an anaesthetist tried to put a needle through the incision where they were going to do the tracheostomy. And you can see what's happening. They're pushing the needle through the front, trying to get it into the trachea. Look carefully for the needle. So we're looking down the trachea. You can see tracheal rings, trachealis at the bottom, and a distant view of the carina. And so this anaesthetist on the outside pushing through, and you never see the needle. And it just shows you how compliant, how soft that trachea is, and how easy it is to collapse, and how difficult it actually is to get a needle in the first place. Next slide, please. Oh,
Previous. Paul?
yes,
Is
okay.
it
I can carry on. This is a study we did looking at ventilation devices through needles, and we looked at pressures and flows. We did quite sophisticated monitoring of those measurements, and we found that all of them, with the exception of the ventrain, were capable of excessive flows and pressures, apart from the bag, which was inadequate for ventilation. So most of them are modified T-pieces. Very few of them, you don't know what pressure you're delivering, you don't know what flows you're delivering, and really they're not suitable. And also there's not much in the literature supporting them. There's only one case, for example, of the Rapid O2 up on the right. The Manujet, the top left, there's some evidence about that. We just look at the next slide. This was a systematic review by Laura Duggan and Adam Law, and they found that complications occurred in 51% of CECO, cannot intubate, cannot oxygenate emergencies when using jet ventilation, compared to elective surgery, which was only 8%. So when you're stressed, you're probably not so careful looking at the pressure you're delivering. So there's very high incidence of barotrauma with jet ventilation. Next slide, please.
Oh.
Oh, we're going backwards. Yeah, so the ventrain's the only device to really consider as appropriate. And in fact, we don't advocate needles anymore in our institution. Next slide. This is a study looking at a tracheotomy technique for children using rabbits as a model. Next slide. And there are a couple of groups in Switzerland doing good work on this. And in fact, there's a study about to come out in anesthesia comparing those two techniques, but they're very, very similar. It involves a tracheotomy below the larynx, about 2 to 3 centimeters, and then you open up the neck, hold the sides apart with those backhouse towel clips. You do a surgical incision just below the cricoid cartilage in a midline direction on the anterior surface of the trachea to make a hole that you can directly place a tracheal tube. Next slide. So these are the key messages from the Canadian Airway Focus Group. Employing frontal neck access through the cricothyroid membrane, that's what CTM is, in a neonate or infant is not feasible or recommended. At this stage, the crocodile membrane is underdeveloped and difficult to landmark. Cartilages are fragile and susceptible to injury. So they're advocating an open tracheotomy. And in fact, that technique is applicable for all age groups, from newborn all the way through to an adult. I don't think I have time really to go through this any further, but that's the main message of that slide. Can I just move to the next slide? And I've just about finished, by the way. I just have a couple of things to say about learning. Next slide, please. So the key points about learning are proper preparation. In terms of managing difficult airways in children, proper preparation prevents poor performance. Be familiar with the guidelines and evidence-based recommendations. Maintain oxygenation, and you can use pre-oxygenation, but also apneic oxygenation. Avoid trauma, and trauma happens by repeated intubation attempts, and also be aware of awareness as a risk of a type of trauma. By preference, use highly successful intubation techniques. So look for evidence for whatever is going to work best, and respond immediately if the child can't be intubated or oxygenated. Don't waste time. Try to maintain oxygenation, do a tracheotomy in infants and older children, and try to avoid barotrauma. Next slide. So this is a quote from Alvin Toffler. He's an author and described as a futurist. And what he said is, the illiterate of the 21st century will not be those who cannot read and write, but rather those who cannot learn, unlearn, and relearn. And I'm sure all those who do research and publish their findings are frustrated when they find that efforts to improve airway management in particular are not being adopted. It's very hard for any of us to change what we do routinely, but we have to keep an eye on improvements and look to learn, unlearn old ideas and relearn with new ones. Next slide, please. So that's all from me. Thank you very much. I hope some of you are still listening. I can't see you out there, but keep an eye on what's about with the literature, and good luck, and thank you for listening to me. Thank you very much. Now, Ricardo, are we going to have any questions, or is there time for anything?
Muchas gracias, querido Paul. Ha sido una experiencia muy grata poder tenerte en nuestro webinario, a pesar de los problemas que hemos tenido, pero que finalmente nosotros, los que tratamos de hacer las cosas bien y cosas buenas para nuestros pacientes, hemos vencido sobre esta otra gente que la verdad es que no sé de cuál es su objetivo. Quiero dar la palabra a algunos de nuestros participantes que quisieran expresar alguna opinión o pregunta para el doctor Baker. Mientras tanto, alguien se decide. Quiero ofrecerle la palabra al doctor Ricardo Latrop, que tienes apagado tu micrófono, Ricardo. El doctor Latrop, Paul, es el director del programa de anestesiología y reanimación. Tienes tu micrófono apagado. Tienes tu micrófono apagado. Tienes tu micrófono apagado. Mientras tanto, el doctor Latrop encuentra cómo activar su micrófono. Yo quisiera comentarte, Paul, que efectivamente, incluso en nuestro medio, en nuestros hospitales, raramente aportamos oxígeno a nuestros pacientes pequeños durante la laringoscopía e intubación. Los pediatras están, en nuestro medio al menos, están muy acostumbrados a usar las cánulas nasales de alto flujo en pacientes que los manejan ellos, pero nosotros en anestesia no tenemos esa práctica de utilizar las cánulas nasales de alto flujo. Y también ahí surge a lo mejor una pregunta que pues, sí, quizás nos pudieras responder, y que si tú has visto en tu experiencia algún beneficio que tenga el uso de cánulas nasales normales, 4 litros por minuto de oxígeno, como has mostrado, versus las cánulas nasales de alto flujo. En el ámbito de la emergenciología, en adultos, los doctores Levitan y Weingart han recomendado el uso de cánulas nasales normales con flujos de oxígeno alto, 15 litros por minuto, con la técnica de no desat. Y eso versus la técnica de oxigenación con cánulas nasales de alto flujo. Pero en niños, no sé si hay alguna recomendación o alguna evidencia que nos puedas mostrar.
Yes, thank you for asking that question. And I have to say, I have a degree of national pride because the Optiflow machine was actually developed in New Zealand by Fisher and Paykel, who have their factories in Auckland, where I live. And I would think we should point out that high flow started in neonatal units in the year 2000. It's been around for a very long time in children. Now, Anil Patel and Reza Nurai published their landmark paper in anesthesia showing the benefit of using it in an adult having laryngeal surgery. And that really exploded the whole idea, and everybody became interested in high flow for adults. But of course, it had been used in children long before that. The benefits in children are the same as in adults. And it's a wonderful technique to use for airway surgery. And a lot of children, in fact, one of the most common procedures we do in our hospital is for children with airway problems. And it's transformed the way we manage the anesthetic. But you do have to change to intravenous anesthesia, of course, but it maintains oxygenation even through very narrow passages of the airway. So we love it. We use it a lot, and whenever we can, it's a supplement to our anesthesia. It has other applications, as I showed you, for transporting children from outside the operating room. Of course, intensive care, emergency medicine are using it. So yeah, it's a great device, and I strongly urge you trying it.
Perfectamente. Ahora sí, doctor Latrop. Doctor Ricardo Latrop, como te decía, es el director del programa de anestesiología de nuestra universidad y siempre nos acompaña. Él es anestesiólogo y sin duda tiene algunos comentarios importantes.
Bueno, Paul, buenos días en Nueva Zelanda. Buenas tardes en Chile.
Good morning, hello.
Ante cualquier comentario, quisiera agradecer en nombre de la universidad, de nuestra Facultad de Medicina y del programa de anestesiología de nuestra dirección de posgrado, su presencia, su charla y su interés y colaboración con nuestra formación de residentes. Por lo tanto, en nombre de todas nuestras autoridades universitarias, muchísimas gracias por haber estado con nosotros haciendo un esfuerzo tremendo para entregarnos su experiencia y sus conocimientos. Como comentario, yo no soy especialista en cirugía infantil como anestesiólogo, digamos. Sí, en mi primera etapa anestesista tenía mucho interés en ser anestesista pediátrico. La verdad es que hay dos elementos que yo creo que usted planteó muy claramente, que es la oxigenación, o sea, el aporte de oxígeno como un hecho relevante de complicaciones principalmente cardíacas o neurológicas en niños que tienen reserva muy disminuida en su capacidad funcional pulmonar habitualmente. Pero un segundo tema me gustaría saber en su experiencia cuáles son las complicaciones del trauma, que usted nombraba como un segundo elemento relevante en el proceso de la intubación frente a una vía aérea directa. Me interesó mucho ese aporte por fibroscopía de oxígeno frente al trauma de la hipertensión bronquial, y que gracias a Dios apareció un hoyito que disminuyó probablemente la presión intrabronquial y el trauma bronquial. Pero del punto de vista de la intubación, me gustaría saber su experiencia sobre las complicaciones que hay del trauma de la
Well,
vía aérea.
yeah, I think one of the common things I see or have seen is children getting airway trauma from repeated intubation attempts, and then putting inappropriately large tracheal tubes down, and particularly little babies, newborns, and they end up with granulation of around and trauma to the airway, or even trauma to the vocal cords, and you get ruptured vocal cords. So there's a lot of problem with probably inexperienced intubation of babies' airways. And I think you can reduce the risk with training by training people better techniques, but also de-stressing the whole event. Because as I showed you in that Hardman graph, you can see that when you're intubating a baby without oxygen, they desaturate very early. They go down at the same rate as an older child, but they intubate early. And so people start to panic, and then they become a lot more traumatic in their actions, and you get more trauma to the airway. So I think if we can set it up so that they're delivering oxygen, they're asleep, probably paralyzed, it's much easier to manage an airway under those circumstances than if you're in a hurry and you're panicking to get a tube in. So I think it all comes with maybe some training and experience, but you're absolutely right. We do see trauma with the airway, and I think they're the problems that arise from inadequate oxygenation, large tubes, being rough on the airway, and trying to do it in a hurry. So use oxygen and set up the airway before you start properly. That would be my advice.
Muchas gracias, Paul. Y nuevamente, muchísimas gracias en nombre de todas las autoridades de nuestra universidad y de la Facultad de Medicina de nuestra Universidad Diego Portales en Chile. Muchísimas gracias por tu participación.
Thank you very much.
Para nosotros ha sido un honor tenerte aquí junto a una cantidad importante de participantes. Así que muchísimas gracias.
Paul, del doctor Raúl Silva de Brasil te envía sus saludos y felicitaciones por este extraordinario webinario. También el doctor Oscar Tapia Salinas te manda saludos desde Huancavelica, Perú, y te pregunta cuál es la incidencia de complicación de broncoespasmo en niños con patología respiratoria alta. Sabemos que en niños con patología alta la incidencia de broncoespasmo es mayor y de laringoespasmo también. Y él pregunta de tu experiencia, ¿cuál sería esa frecuencia de broncoespasmo en estos niños con patología respiratoria alta?
It's very, very common. I can't give you a figure, I'm afraid, but particularly with winter coming, as it is in New Zealand, we see more respiratory tract infections. We had an epidemic a few months ago of respiratory syncytial virus, and a lot of children had airway problems. When it comes to anesthesia with those children, their airways are far more irritable. I like to use local anesthetic spray before I instrument the airway, and muscle relaxants, but they can be very problematic and they can desaturate very quickly. So you need to supplement with oxygen.
Muchas gracias, Paul. El doctor Juan Carlos Mandujano envía muchos saludos y felicitaciones desde México. Dice, es difícil la situación de manejar al paciente pediátrico, en especial al menor de 1 año. En México se ha considerado que solo deben ser abordados por un especialista, lo que en algún momento hemos tenido oportunidad de manejar pacientes pediátricos, se refiere a especialistas en niños, dedicados a niños. Los que hemos tenido en algún momento la oportunidad de manejar pacientes pediátricos, aprendimos a manejar la oxigenación durante la fase de preoxigenación junto con la preparación para el aseguramiento de la vía aérea, a diferencia de varios neonatólogos que hacen laringoscopía con el bebé sin analgesia, sin relajación y con un paciente combativo. Eso.
Sorry.
No sé si quieres responder.
I agree. That's a potentially very traumatic practice to intubate babies unmodified with no anesthetic, and often inexperienced people doing it. It can lead to trauma. So you have to be very careful with those little babies.
Perfectamente. Yo creo que estamos al final del webinario. Hay algunos saludos que te envían desde Venezuela también, desde Tijuana.
Oh, excellent. Yeah.
Tenemos auditores de participantes de muchas partes. Voy a compartir mi pantalla nuevamente. Compartir mi pantalla para avanzar. Aquí empezamos el año 2021 y nos veían desde varias partes de Sudamérica y también algo de Norteamérica. Algunos colegas, amigos de España, etc. Y hoy día, el año 2022, el que recién pasado, hemos aumentado muchísimo nuestra cobertura. Incluso hemos llegado a lugares insospechados. Esperamos también poder llegar a Oceanía, a Nueva Zelanda, a tu país, y también a Australia. De a poco hemos ido avanzando en nuestro afán de poder llevar la mejor información científica disponible en el manejo de la vía aérea hacia nuestros colegas de Latinoamérica. Y en este sentido, te estamos muy agradecidos, Paul, por tu importantísimo aporte que hoy has hecho para el manejo de nuestros pacientes pediátricos que tienen especiales características que los hacen mucho más vulnerables frente a la hipoxia que los pacientes adultos. Así que muchas gracias. Estamos también en redes sociales, en Facebook, estamos en YouTube. Esta conferencia va a ser con tu autorización subida a nuestro canal de YouTube, como muchas otras desde el año 2021. Estamos también en Instagram y en Twitter, que también publicamos nuestros avisos de que se va a hacer un webinario. Y el próximo webinario, que va a ser el día sábado 28 de junio, va a participar la doctora Laura Reviriego Agudo, quien es una anestesióloga española, y quien nos va a hablar acerca de cómo enseñar la intubación con el videoendoscopio flexible, antiguo fibroscopio, ahora videoendoscopio flexible. Así es que los dejamos desde ya invitados para participar y unirse a este webinario tan interesante el sábado 24 de junio con la doctora Laura Reviriego, que nos va a ilustrar sobre este muy importante tema de cómo enseñar y cómo aprender esta técnica tan útil. Así que les doy las gracias a todos. Muchas gracias, Paul, por tu importantísimo aporte, a pesar de los problemas que tuvimos, pero los hemos vencido y salimos adelante con el webinario. Eso es lo más importante y te estamos muy agradecidos por tu colaboración y tu contribución a nuestro quehacer. Muchas gracias, Paul. Y gracias a todos, gracias a opciones remotas y a Martín.
Gracias, Ricardo. Que estés muy bien.
Buen fin. Muchas gracias, Paul.
Fecha. Thanks, Ricardo, for organizing it.
Muchas gracias. Bye, bye.